Basically, the outlines of my talk will be first is to introduce some of you who might, uh, who might never heard about terms and concepts surrounding outbreaks, investigation, and response. And then secondly, a little bit of information on why we should investigate outbreaks and step by step in an outbreak investigation and also response, and a couple of real world examples throughout my slides. I'd like to start my talk with a little bit introduction about what is an outbreak or epidemic, or in Indonesia we used to call it long time ago. I think we used to call it as wabah, but then I think it is more friendly when we call it as KLB, right? Kejadian luar biasa nowadays. Um, so a little bit of a definition about outbreak or epidemic. I think these two terms, just like in Indonesia, we use it interchangeably. Like sometimes we say KLB, sometimes we say wabah. There is no right or wrong time of saying both, KLB or wabah. But normally, when it is more politically correct to say it as KLB, right? Because I think um, it won't cause panicking in public, for examples, or sometimes it is also useful to say wabah, right? For examples, when we are trying to deal with very serious situation and we want to catch public attention, and we want for the community to not only watch the epidemic is happening, but also we want them to be actively get involved in terms of having us in a controlling the epidemic. We sometimes say, "Oh, it is wabah," right? Uh, and I think news like to use wabah instead of KLB because I think it's has more selling value. So when we do outbreak investigation, we of course we always need to uh, consider several factors, which I believe you, as a student, as undergrad student, already got this concept from introductory epidemiology unit, where we always try to describe everything based on what we call as in Bahasa, I think it's OTW, right? Orang, tempat, waktu. In English, it's person, place, and time, and also uh, historical incidents of certain diseases. So don't get confused with with other terminology like pandemic. Of course, the terms of pandemic I think has became really really famous lately due to the COVID-19 pandemic that's really really hit global health security, that shows how vulnerable our pandemic preparedness and response are. So why do we investigate outbreaks? Of course, as a public health professional, the idea of investigating outbreak is to protect health and well-being of the population. The outbreak investigation involve outbreaks detection, and then based on the outbreak detection and investigation, then we want to control the transmission, of course, to prevent for further impact. We also want to identify the risk so that in the future we can implement the prevention strategies to mitigate any risk of outbreaks that might occurring in the future. Um, the event of outbreaks also may offer us a learning opportunity. For example, during the outbreak, we can do many things. We can ask many research hypotheses. For example, during outbreak, we can test. For example, if the outbreaks of vaccine preventable diseases is happening, for example, then the opportunity may offer us, chance to, for example, evaluate herd immunity level. We can then evaluate vaccine effectiveness, for example, by doing case control studies and so on. And also, it offers us opportunity to, to train and then develop what we call as apa ya bahasa Indonesia tim gerak cepat, right? Rapid response teams during the outbreaks. I think it's also one good effect of COVID-19 is that now I think across the country we do have quite good rapid response team because during the COVID-19 we train many people, we train many workforce and so on. I just wanted to highlight that surveillance is actually a key to outbreak detection because why is it the case? Um, to be able to detect a potential of outbreaks, of course, we need a really, really good surveillance. And this has been regulated internationally under the International Health Regulation in 2005. And also in Indonesia, I think we do have Peraturan Menteri Kesehatan tentang pedoman penyelenggaraan sistem kewaspadaan dini dan kejadian luar biasa that legally what you call it that legally regulate and legally guide how we should do um, early warning detection and also outbreak investigation and response. So it's not only ethically become our responsibility as public health professional, but also it is also mandated by both international and national regulation. Specifically under the IHR, countries are actually required to report cases that have a potential to become what we call as public health emergency of international concern. Again, I think these terms also became more popular, especially after COVID-19, right? So let me try something just blocked my slides. Wait a second. I'm trying to hide the floating meeting controls. Okay. Um, so how do we define this, what we call as a public health emergency of international concern? Basically, um, it's an event that where the public health impact is serious, for example, like COVID-19 or Ebola, for example. The event is unusual or unexpected. Uh, let's say monkeypox. We didn't expect to have monkeypox, but then suddenly we got some cases, for example, in Jakarta. So that's also something serious. There is a significant risk of international spread. Of course, this is particularly relevant to diseases that being spread through air, for example, airborne diseases what is currently happening. For example, I think influenza A currently circulating here in Indonesia and other countries as well. And lastly is if certain outbreaks is posing a significant risk for international travel or trade restriction, just like during COVID-19, when we know that human mobility really play key roles in you know maintaining or sustaining the transmission in population because people can come from high transmission setting and then travel to area where there was no cases. But then once it get new cases, then the outbreaks happening. So that's just a few example of an event that might be considered as a public health emergency of international concerns. Okay. And who determines PHEIC? I think we now are already aware that it is the duty of the WHO Director General who can make a committee of experts and then they will be deciding whether a certain condition is considered as a public health emergency of international concern or not. Since 2005, there have been six um, PHEIC declaration spanning from H1N1 influenza virus pandemic in 2009, and then the last one is, I think, COVID-19 pandemic in 2020. Now, I previously mentioned that surveillance is a key to outbreak detection and response. Now, just a little bit of refreshing slides around what is public health surveillance. Basically, we define public health surveillance is an ongoing and systematic collection of data, followed by certain analysis, interpretation of data, and then dissemination of the data to be used to form certain public health response or intervention. In the case of outbreak detection and response, of course, a really good surveillance might be a really perfect tools for us to detect not not only detect the outbreak, but probably detect the potential of outbreak. So with a good surveillance data, we should be able to um, prevent an outbreak from occurring. But in reality, of course, our surveillance system has a lot of limitation. That's why we do have several outbreaks happening. So I think Pak Lukman just mentioned about the food poisoning outbreaks from uh, the recently implemented policy. I think it was implemented in January 2025, right? And I think so far, according to what I can recall, there has been more than 16,000 cases of food poisoning among school children that are receiving the uh, free school meals. Yeah, free that are receiving the free school meals policy. But of course, we know that from that outbreak, then we know that we are really lacking in terms of public health surveillance, specifically for the implementation of the makan bergizi gratis. I think based on discussion in several group of field epidemiologists, professionals, it was highlighted that the lack of surveillance is particularly because I think in the implementation of MBG, the district health office and the Puskesmas is not directly involved as part of the uh, program implementation. So that's why often they only got the report about the outbreaks after the outbreaks happen. So the good surveillance, have a lot of function, but I think the highlight in this slide is that the good surveillance should be able to do outbreak detection. But due to the limitation of our surveillance, good surveillance should be a surveillance that have a good completeness of data, good timeliness of reporting, good sensitivity, flexibility, and so on. But it's often not the case in the field. It's often in the field, what we found is that our surveillance data are incomplete, are messy, often are not timely. So that's why then often we know the data even like months after certain outbreaks happen due to the delay in reporting in field. So when we interpret surveillance data, analyze and interpret surveillance data, we need to be mindful of the objective and limitation of the surveillance. We need to be sure what it can tell us, what it can't. When we examine the data based on person, time, and place, we also need to consider certain factors. For example, whether certain diseases ever occurred before. That means that we have to establish the baseline. For example, um, let's say the current global example. For example, in Europe, in European country, they uh, they've never experienced any local transmission of chikungunya, for example, because in country like France and Italy, the mosquito vectors that are transmitting chikungunya cannot survive. Therefore, the transmission cannot be happening in that settings. But just recently this year, I think in late May, March or May 2025, there has been an outbreaks of chikungunya in 11 areas in France and several areas in Italy. So that's happened because they suspect that the rise in temperature, so climate change, environmental change, had played important roles in then introducing a risk of chikungunya outbreak in those particular settings. So the baseline data is they've never had any chikungunya cases before because the environment is not favorable for the mosquito to be able to transmit the disease. But now, due to recent change in a climate and environment, they suddenly have cases of chikungunya. So in that case, because the baseline is zero case of chikungunya, and now they have one or two cases, that will be sufficient for them to call it as an outbreak, right? So that's just example that of an outbreak that's just recently happened in Europe. Um, and when we examine surveillance data, we also need to be careful. For example, we need to consider whether there's been changes that might impact the case notification. For example, let me give you examples from TB, for examples. When we read the time trend of TB case notification, for example, even though we saw that, let's say, the cases being reported this month, this October, is twice the number of cases in being reported in September, for example. But we need to be careful. Uh, what do I mean by we need to be careful? Before interpreting it as an increase of number of cases, like twice the previous month, we need to be cautious that probably the increase of case notification is not directly due to increase of transmission. It might be because of in October, there is an active case finding, there's an active screening happening, for example, in a prisons, in a household contact of TB patient. There are simply then make number of cases looks like as if it is twice the number of cases in the previous month. So when we interpret the surveillance data, we need to be cautious of those kind of context. Same things happen when we observe the decreased number of, for example, measles cases, right? We need to be cautious. Is it really because of, for example, a good coverage of vaccination, or is it because of there is a decrease or a funding cuts that then impact the case finding? So we observe a lower number of case of measles, not necessarily because of the success of our programs, but it's merely because we don't have much money to do routine things that we used to do. So therefore, then the case finding become decreased. So we need to apply those public health contexts when we examine surveillance data. Um, Before I go too far, Pak Lukman, do I get to take a question now, or do we do it later on?
Uh, it's okay if we have a question from the student.
Yeah, that's
Okay,
okay. I mean,
okay.
because the slide is quite long, right?
Yeah,
And it's
okay.
90 minutes. So if the student have a question, then just feel free to raise their hand or just speak directly before I go too far. Anyone? Because to be honest, I'm sharing my screen, so I cannot see anyone else.
Yeah. Okay, student, would you please to ask the question?
It's going to be long. If you don't have a question, it's going to be a long, boring session.
Uh, from my question, I have my question that you
Sure.
share about the mosquito disease, yeah, the
Yeah.
mosquito in Europe.
Chikungunya. Yeah.
So is it possible if the disease like neglected disease is only happen in Indonesia? Is it possible that in the future it can be rise or happen in the area that now in zero case?
That's a really interesting thing. Interesting question. Actually, it's happening now. It's happening now. Uh, yeah, chikungunya is one example. Another example is leptospirosis. Leptospirosis used to be neglected tropical diseases in Indonesia, right? Because
Mm.
we do have the disease in many settings in Indonesia, like for example, in Jakarta, West Java, and also in Bantul Regency in Yogyakarta, because the risk of leptospirosis is highly associated with occupational risk. For example, people farmers not wearing, of course, our local farmers, they are not wearing shoes, right? They just go to the rice field and then they get infected there. Um, and in other contexts like in Jakarta or West Java, flooding is increased is a normal thing now, but it's becoming more and more frequent, and then therefore it increased the risk of leptospirosis. Just recently, I heard from colleagues from UQ, from University of Queensland, that at international level, and there is now a massive movement between, among those scientists who used to, care about leptospirosis in small regional level, and now they bring it together to become a global, what you call it, a global movement that in the future hopefully will be acknowledged by the WHO. So the goal is to to make the WHO acknowledge that leptospirosis is actually a global neglected tropical disease because some areas in Pacific Islands is now experiencing increase in cases of leptospirosis. That's just another example. So yeah, so if chikungunya can make it, probably other diseases can also make it, like Zika, probably. So it's scary. Yeah. I
Yeah,
hope
yeah.
that answer your question, Pak Lukman.
Okay, thank you. Uh, it's okay if the question from bahasa Indonesia, Bapak Ibu, teman-teman
Yeah,
mahasiswa semua, it's okay.
yeah,
Oh,
yeah.
there is
Saya orang
question from
Indonesia.
there is question from Pak Agus ya. He is if I'm not mistaken, he is from doctoral degree.
Oh, okay,
The
cool.
question is with the increasing number of case in the free nutritious food program causing the food poisoning, many healthcare workers in health facilities seem unprepared yeah, to handle this outbreak.
Mhm.
What do you think about this? About the makan bergizi gratis?
Yeah, it's actually, um, I myself with my other two colleagues, we just submitted the a commentary opinion actually about this MBG policy to a scientific journal, and it's under review now. But from what we observe is that there are quite a lot of a major food safety risk there because I cannot recall my data, but I think a couple of days ago I just checked that, for example, like out of more than 10,000 SPPG, for example, if I'm not mistaken, only 26 or 27 of them who already got the international certificate. So that's, that basically, say that, oh, okay, you fulfill the international standard of handling food. And if I'm not mistaken, I do have the data, but it's on my manuscript. It's also only few of SPPG that are actually, what you call it, have been certified for hygiene certification. I think you can easily get the data from the BGN website because I that's where I got the data from. And in terms of the was it the readiness of the health facility? Yeah, is that the question? Pertanyaan tadi
Yeah,
tentang
in health
yeah,
facilities
yeah,
seems unprepared yeah, to
yeah,
handle this
yeah,
event.
exactly, exactly.
Tidak siap. Nah,
Why,
istilahnya
yeah,
tidak
why,
siap.
yeah, why they're not prepared actually?
Pak
Because I think
Agus,
from yeah,
sorry Henry,
yeah,
Pak Agus will confirm. Pak Agus, okay in
Ya,
bahasa, you can
yeah, tidak
eh,
siap ya.
give the
lebih baik
statement.
bahasa Indonesia saja, enggak apa-apa.
It's okay.
So,
Iya.
Pak Agus mau menambahkan atau mau mengulang
Begini, Pak.
pertanyaan?
Eh, Istilahnya kita selaku nakes di Fasiankes dengan adanya keracunan dalam jumlah yang banyak tidak siap, Pak. Baik datanya, sumber daya, dan
see.
lain-lain. Begitu, Pak.
Yeah, I mean, yeah, of course, yeah, I can imagine that, particularly because from what I understand, this BGN is a newly formed, right? BGN baru kan, a newly formed entity, and then they are being led by people that, let's say, who are not coming from public health background, for example, or not coming from food security or food security background, for example. So From what I understand is that during the implementation, the Puskesmas and district health office is not directly involved as part of the implementation, right? So that's why the lack of coordination or the lack of collaboration, lack of involvement of the uh, Puskesmas in this implementation will keep, will what do you call it, will only put additional burden uh, at the end of the day. I mean, if the Puskesmas being involved in the implementation, probably they can help monitoring it, right? They can help making sure that the food are handled in a most hygiene way. The food chains, for example, are safe, and so on and so on. And they can also make sure that before the foods are being consumed by the student, they can be there, making sure that it is okay. I think if that's kind of investment implemented now, in my opinion, it will avoid an increase of cases. It will avoid 10,000s of cases that might happening in the future. So I don't think the problem is in the readiness of the primary healthcare part, because at this point, Puskesmas, they cannot do anything, right? They just wait for the cases to come. Has they been involved in the prevention? Probably, then it would have been way better in this sense. So that's why in one of our recommendation to the program actually is that to get them involved from the beginning, from the implementation until the monitoring of the MBG. I hope that adds some insight.
Okay. Henry, before you continue your PowerPoint, we have two questions, but uh, I will ask one question and you continue with your slide, and then
Sure,
the
sure.
next question in after you share the slide. The question from Delia, one question. She's from international bachelor program. That you said before about the pseudo epidemic, yeah, pseudo
Yeah,
outbreak, yeah,
pseudo
pseudo
outbreak.
outbreak. The question is like this: the enhancement of disease can probably from the improvement of diagnosis detection, or it may
Exactly.
be improvement of reporting system. In your point of view, how we distinguish whether it is true outbreak or it is a pseudo outbreak?
Yeah, that's really good point. I mean, I just gave a example of TB, right? Because I think lately TB, there is huge expansion on TB case finding by implementing by distributing gene expert. So that means that now TB cases diagnosis is becoming faster. That also means that more cases were likely to be found, but it doesn't necessarily mean that it is an increase of transmission, right? So how to distinguish that? I think how to distinguish that is that to compare the data using similar context. For example, if previously TB cases are only being detected by, let's say, smear, sputum, right? Sputum test, then we can only compare those with what being found based on smear, right? In the same context, because adding gene expert itself will improve the sensitivity of case finding in a way. So we cannot compare that. So what I'm trying to say is that when we compare things, we need to make sure they are comparable. You know what I mean, right? I hope that's the key. The key word is comparability. So we cannot compare apple with mm, like with apple with orange, for example, right? Or green apple with red apple. So it's just like that, I think.
Okay, yeah, and you can continue your slide.
Okay. Yeah, I've got quite a lot of slides actually, but it's good. I mean, it's good to have a question because that means that you are there. I'm not speaking alone in here. Oh, okay. So here is just example of how we can use surveillance data to detect an outbreak. If you see in this graph, actually this one is generated from one of my colleagues in Australia, where they try to identify, the threshold. Well, I think to make it simple, if you happen to work with Puskesmas or district health office, they normally will make a simple line graphs, what we call it, that we used to call it as a graphic minimum and maximum, right? I think that would be the easiest illustration for this. So uh, in this case, they try to do a fancy analysis, but you don't need to know, I think, how do they do that. The important point is that we can actually establish the threshold. So the blue broken line in here is the threshold. Threshold means that if the number of cases in that particular time exceed the threshold, that means that the outbreak has happened. So, for example, in here, from 2015 up to 2000 and close to 2017, there was no outbreak of Ross River virus in this particular Victorian setting in Australia, as you can see, because the true number of cases is the black line here. Can you see my pointers? Yeah, here you can see it from 2015 to 2016, like the black dot, the black line is always under the threshold. Threshold is a batas atas, right? Batas atas. But when you see it here in by the end of 2016, you can see that the true number of cases being observed is actually exceeding the threshold. So uh, in terms of outbreak detection and response, so once you observe this by the end of 2016, then this is when you have to act quickly, right? Because you don't want the case then become increased rapidly like this. But I think in these cases, also the outbreak investigation and response was quite late, so that's why it's happening. That's why they call it outbreak, right? So they didn't manage to prevent the outbreak. So you can see it here. By over time in 2017, the number of observed cases far away exceeding the threshold. So this is just an example of how we can use surveillance data to detect outbreak from a computer screen. Now I'm gonna talk a bit about step by step of an outbreak investigation. I got informed that some of you who have a major or minor in epidemiology have already got this information, but there are some of you who have not got this outbreak investigation step-by-step information. So I'm going to go through this one by one. So what is an outbreak investigation? It's basically a core task of communicable disease control, infectious disease control. It involves scientific process because we generate hypotheses, we do a study, can be case control, can be cohort study or cross-sectional, and the goal is to generate knowledge and then use those knowledge to implement appropriate control measure or to implement what we call as public health intervention. Here is the model of disease investigation. As you can see it here, earlier I mentioned that we use surveillance data and then we use their statistic, we analyze them and then we interpret them. And based on what is our objectives, for example, we want to detect the outbreak, so that's our objectives. What is the context? We know that is there a newly implemented intervention? Is there a newly implemented diagnostic? So we need to keep in mind the objectives and the context, and also the theory that is supporting our thinking when interpreting data. What I mean by the theory, for example, uh, when we try to detect an outbreak of, let's say, dengue, we know that in theory, in reality, we know that dengue will tend to be increased during, for example, rainy season, right? So there is a theory supporting that we expect to get an increase in terms of number of dengue cases when the seasonality factors are favorable for dengue transmission. In this case, we can assume that when it is close to rainy season, then probably we will expect to get increase of dengue transmission. So here we do the interpretation. If we observe that the data is just under the what you call it the maximum line or the threshold line, then we just wait and observe and do business as usual. But if we see there is a spike in terms of number of cases, then ideally what we should do is to develop a testable hypothesis. For example, is there an outbreak? That's also a hypothesis, right? Is there an outbreak? Then we go to the field and confirm our hypothesis, for example. And another kind of hypothesis in the example of dengue is probably um, does this increase of cases associated with uh, the increase of what we call it rainfall, for example, or in the case of malaria, for example, does the increase of malaria cases align with the increase of, for example, people coming or returning from high endemic setting. For example, we know that malaria normally occur during what you call it, mudik season, because people traveling to Papua, working in Papua, for example, where malaria is still high, and then during after Idul Fitri, they went back to their hometown, let's say in Semarang, where there is no malaria, for example, but uh, eventually, because in some part there is the mosquito, and then those people can reintroduce malaria in that site, for example. So those kind of hypotheses that we can develop, and then based on the finding in here, we can then use it to make a public health action. Those in
Henry, wait,
theory, it's like that.
sorry.
Yeah, so yeah.
There is a question that you said about the season. The question from Burinda Sari that uh, her question is, how does seasonality affect the interpretation of the surveillance data?
How does seasonality affect the interpretation of surveillance data? No, I think when uh, when we know, yeah, of course, it requires a more advanced analysis, right? So the simple surveillance data that are just describing a trend of cases will not be sufficient when we interpret the data of certain cases that has additional factors, or we can say that has what you call it. It might be like not confounding, but it might be can be called as a effect modifier. We also needs to do a more complex kind of what you call it uh, time trend analysis. So in the case where the time is also associated with certain things like seasonality, like rainfall and so on, then we need to be cautious because it also means that probably when the seasonality hit, the normal the threshold should be also higher than the threshold when it's not raining season, for example, right? Do you get it? Do you get my point? Uh, so with that being said, more advanced statistical modeling will be required. So then, every time we interpret our data, we know, and we expect that okay, the increase of certain cases, for example, is due to seasonality, or in this case, it can be due to increase in rainfall or increase in human mobility. Therefore, when we interpret the data, the surveillance data, we will then be able to even act uh, before the increase might also happening, right? So my point in here is that in nowadays technology, we could no longer rely on only time trend data of cases. For example, one of our works at the moment for malaria and dengue, we are trying to transform the way we look at the surveillance data, because what we observe so far is just based on the reported number of cases, right? But by using satellite data that will enable us to get data on rainfall, humidity, environmental changes, and so on. By using those, we can actually then we can do modeling, and then we can find out when is the most likely time for example, for dengue outbreak might happen. Because at that particular point, uh, the seasonality factors may play a really, really important role. So in that case, um, probably just looking at dengue cases information is no longer sufficient. So what we hypothesize is, instead of using basic surveillance data, in that certain cases, it is even better if we just use, like, for example, a rainfall trend, for example, whether there is a forecast of certain extreme climate, for example, extreme rainfall, and so on and so on. So we use those as a signal or alert to then quickly, act or prevent the outbreak from happening. So that's what I mean. I'm sorry if you got confused by my explanation.
Okay, thank you. Mr. Hari, Pak Hari, you raise the
Oke,
hand. It's okay.
thank you, Mr. Lukman. Oke,
In bahasa it's
Assalamualaikum.
okay, Pak.
Ya, latihan bahasa Inggris ini.
Siap, siap.
Mau ke LA masalahnya. Mohon maaf, I'm sorry. Oke, thank you, Mr. Lukman for attention. Assalamualaikum, Prof. Henry. How are you today?
All good, Pak. Alhamdulillah.
Oke, my name Hari Rujijanto Ibe from Postgraduate Public Health and Faculty of Medicine Universitas Negeri Semarang. I work in Poltekkes Kemenkes Semarang. I need your opinion ya, opinion. So last 1 week a day, I read the latest news in about the tuberculosis vaccine program Indonesia. This is vaccine from Bill Gates Foundation. So I have a question from you, Prof. Henry. Number one, how does the TBC vaccination policy in Indonesia contribution to preparedness in facing potential TBC outbreak? Number two, will the TBC vaccine eliminate the disease of Indonesia, of course? Number three, where the vaccine TBC in from Bill Gates is to Indonesia? Where about to Africa or Southeast Asia? Where the choose of Indonesia?
Okay.
Thank you,
Thank you, Pak.
Prof. Henry.
Can I get the first question repeated? What is the first one?
How does the TBC vaccination policy in
Oh,
Indonesia?
okay.
Oh, okay.
Okay, I get it.
Okay.
Maybe thank you very much, Pak. Maybe I'll answer the last two. Why Indonesia? Why not other Southeast Asian country? Because I think based on statistic, Indonesia is the second highest TB burden country in the world, and the fact that in Indonesia we do have capacity. So for RCT, randomized clinical trials, it cannot just be done anywhere. So they need to make sure that the country also have the capacity. In this case, I think Indonesia, some institution in Indonesia have the capacity to do RCT. So I think it's a matter of one, it's the fact that we have the second highest TB burden. Second, we also have the local capacity, and three, I think there is a political support in this instance. So that's why I think the vaccine trial is done in Indonesia. I was actually well, I nearly got involved in that, but I didn't, which is also a good thing. Secondly, will implementing vaccination eliminate TB? That's a hard question, but I think the easy answer to that is no. The easy answer to that is no. I think there are certain mathematical modeling that show that um, effective vaccination may help to reduce TB transmission among adults, right? But of course, we know that vaccination itself has their limitation in terms of they cannot protect 100%. They cannot give you 100% immunity. The vaccine effectiveness might be only 60%, might be 70%. So that means that we cannot just use vaccine to eliminate TB and other complex public health contexts in Indonesia. Like for example, there is a um, um, vaccine hesitancies in certain places. There are certain beliefs that just refuse modern technology and so on and so on. And the fact that Indonesia is so huge, we have nearly 300, is it 300 million now population. So I don't think we can cover all of the, or I mean, I don't think we can reach like even like the intended threshold of herd immunity. I don't think vaccine alone can eliminate any other diseases, but so that would be my honest answer to that. For many reasons, I can speak about immunology as well. For example, like immunologically speaking, the level of immunity may be waning, but maybe waning. So for certain time, we don't know like how long that the TB immunity induced by the a new vaccine will last. We don't know whether it will last like 20 years, 30 years, and so on. So there are many things that may support the idea that vaccine alone will not be able to eliminate TB. And the first question, what about the vaccination policy? I think so far we don't have policy for TB vaccine among adult, right? Because what we have at the moment is just BCG, yeah, vaccine, which is for kids, which is for children. I think it's a long way to go, but after the new TB vaccination trials, shows a promising result, then probably from there we can find out what our government may say about it. So sorry, it goes actually beyond outbreak investigation and response. But I think it's a good question. Thank you, Pak. Shall we continue, Pak Lukman?
Yeah, you can continue, Han.
Okay, because it seems like we discuss many things,
Yeah.
which is interesting. But let's keep on this topic. So basically, there are 10 steps in an outbreak investigation. Is starting from confirming existence of an outbreak, whether it is really outbreak, right? Like one question, is it pseudo outbreak or true outbreak? And then we need to verify the diagnosis. Ideally, it should be based on lab confirmation, but in reality, many of our diagnosis in the field is not based on lab, mainly based on clinical diagnosis and epidemiological consideration. And then construct a working case definition. We need to make it specific, and so on and so on. I will go run through the slides one by one, the steps one by one. I think the first one was, I think we had discussion on this. Of course, we need to compare the temporal pattern. When I say temporal pattern, it means um, time trend, right? I think in more generic language is time trend. There are many definition of outbreak. I think one of the easiest one is that if a certain disease is used to be absent, meaning there was no certain disease previously, and then suddenly we got the disease, then that's an outbreak. Or when we compare the temporal patterns, for example, like now, probably, let's say we do have a case of measles in, let's say in Semarang, we do have like 500 case of measles in Semarang in October. And then when we compare it to what happened in previous month, let's say previous month there is no cases, then we can say it's an outbreak. Or in the previous month it's only 100 cases, and then we now know that in this October the number of cases is like more than 2 times, then we can say that's an outbreak. But of course, we can always we can easily say an outbreak from an academic perspective because we know the science, right? Outbreak means that something that is unusual, something that is unexpected. But in reality, politically, um, there is a law, there is a guidance on who should say or who should declare an outbreak. I think in this case is a bupati, right? Bupati is the smallest what you call it government authority that can call an outbreak in a district or kabupaten level. Um, because why is it the case? Because it has a political implication. When an outbreak is declared, that means that uh, what do you call it? The local authority or the Pemda, they have to take care of the outbreak. Then that means that they have to be ready financially then to cover the cost, whatever cost that whatever the cost raised during the outbreak investigation and response, they have to cover it because then, according to the current policy, for example, because we are using BPJS, right? BPJS will not cover those any medical costs that's happened during a formally confirmed outbreak. So sadly, that's reality. So it's all about politics as well. Um, I think this is just basic. Of course, when we describe data, we always need to describe it based on person, place, and time. I think I'll just skip that. This is also just resonating on my previous point that we need to make sure it is really, really real. Uh, is it is it is the increase just because of the improved diagnostic, for example, or there is a new doctor in town, ada dokter baru, kemudian karena saking semangatnya, right, overly excited, then they just overdiagnose people and so on and so on. So the key point in here is we need to make sure it is real. It's not pseudo outbreak. Um, Second step is verifying the diagnosis. This is really important because the control measures, if we talk about the concept of infectious disease prevention and control, each disease has their own specific control measure, right? Because each disease has their own modes of transmission. For example, um, if it is foodborne, then we have to find out the food causing it, and then how to cut the prevent the outbreak in the future. If it is airborne diseases, then we have to confirm it. So then we can then advise people to wear masks, to maybe to do some sterilization and so on. So it's really important to do the diagnosis verification. How to do it? Many things that can be done. Like I said before, ideally we should do laboratory confirmation, but in many circumstances in real life, I think we just cannot do that. So many of cases in the field or diagnosis are just based on clinical diagnosis. Um, then we need to construct a working case definition. For example, let's use MBG as an example, right? Case definition of MBG need to be really, really, what you call it, need to be really, really specific in terms of where it happened, when it happened, and who are the population. For example, if it is happening in a one school, then we have to restrict the case definition to to the people there. So for example, so we know that they have a clinical symptoms like abdominal pain or diarrhea, um, and they are a student in X school. Then the case definition should be like any students in X school that has diarrhea or abdominal pain. It's as easy as that. And then from there we can then do a further investigation whether what's happening to them are only due to the makan bergizi gratis. If yes, in which day, which food, and so on and so on, right? These are just example of
Hen,
yeah,
there is a question from the student.
sure. Yeah,
Delia, are you there? You can open
Yeah,
the microphone.
yeah.
Okay, you can.
Go ahead.
okay, I want to ask towards the TB vaccines that we need to plan. Does the vaccine needs to be specified as well, since there are any multiple cases of TB like TB resistant obat or TB HIV towards these
Mhm.
cases? Thank you in advance, Prof.
Thank you very much. Yeah, you're right. TB, there are a lot of kind of TB. There are TB latent, there are TB resistant, there are TB extra pulmonary TB, and so on and so on. But I think the idea of vaccine is supposed to prevent to prevent the TB infection, right? So I think whatever they don't need to. The idea is that to prevent it for the infection to be happening, so not necessarily to just to prevent it from the severe condition. So in this case, I think we don't need to worry about that because the vaccination is to prevent everyone, right, from getting infection of TB. So the idea of having a good TB vaccination is if someone get exposed through the Mycobacterium TB, right, then their immunity will be sufficient enough to counter to attack the TB pathogen, so then they will not develop the disease. So they may still get exposed. Of course, you cannot. The only way to prevent ourselves from getting exposed to the TB pathogen is, of course, to not get in contact with someone who has it, right? But that's not ideal. So that's why in this case, we assume that people will be likely to get exposed by TB in anywhere in the context of in Indonesia, because TB is everywhere, right? So the idea of a vaccine is not to prevent it to get inside our body, but rather to, if the pathogen enter our body, then our immune system will be able to quickly recognize it as a TB, and then we can quickly fight it because we already develop a certain antibody from the vaccine. So therefore, we will not going to be sick, and hopefully we're not going to be infectious. Therefore, we will no longer make other people also infected. So I think no, we don't really need uh, to um, to distinguish between those type of TB. I think those type of TB, different type of TB, need to be distinguished in a way when we try to develop, for example, screening program, because each type of TB will have different strategy. I mean, like if we want to capture latent TB means that they already got infected by TB, right? They already have the pathogen in their body, but they are not in the um, infectious, or they are not in the disease stage. So they are still healthy, just healthy. They are latent, but they are healthy. So the screening will be to target those people who are still healthy, but probably already got exposed to TB. So it can be TB screening in a prison, TB screening among people who have diabetes, and so on and so on. I hope that answered the question. Let's continue.
Okay, yeah, you can continue.
Yeah, so this is just example of a case definition. Of course, like I said before, we laboratory confirmation is not ideal in many settings, especially in Indonesia. So therefore, uh, based on their condition. It can be probable cases based on the knowledge that we know. For example, it can be probable, which mean, oh my God, am I still connected? Hello?
Yeah, you are still connected.
Oh, okay. Because the connection said it's unstable. Okay. Or it can be confirmed cases, meaning that we do have a level 3 definitive evidence. Then we can say, oh, okay, it is confirmed measles, or it is probably just, like I said, it's probable because the laboratory suggests evidence, but there is no clear confirmation laboratorily, and the clinical evidence also support that whatever they are experiencing is aligned with what we know about measles clinical condition. I think I've mentioned this before about making our own case definition to be outbreak specific. Like I said before, we can move on this, I think. The fourth step is active case finding. Once we establish and verify the diagnosis, then what we can do is then to find more cases. Just like during COVID-19, right? We do a lot of case investigation, contact tracing. The idea is to find as much as cases as possible. Therefore, then we can, prevent them from getting sick and prevent them from spreading the disease further to community. This is just example of systematic data collection thing. We used to use a paper-based questionnaire, but I think nowadays you can easily create your questionnaire electronically using certain free software like EpiCollect, Kobo Toolbox, and so on. You can easily make the list of question. Of course, then the question being asked, it has to be has to be relevant to the disease that being investigated. For example, if it is TB, then you don't need to ask whether someone is sleeping under bed net, because bed net is prevention for malaria. I think you know what I mean. Then after we do that data collection, active case finding, then what we should do is that to perform descriptive epidemiology. Remember OTW, orang tempat waktu, person, time, and place. We describe our cases based on age, based on gender, based on the clinical symptom, based on their onset of illness or incubate onset of illness, and so on and so on. Then from there, we can do more statistical analysis. In this case, I hope you are familiar with this. Attack rate is basically an incidence rate, which represent a number of cases that meet case definition. Out of a total of population that we believe are able to be exposed. But we use attack rate terminology in a case of outbreaks. If it is not an outbreak, then we can use incidence rate, right? And there is also another form of a statistic, which is case fatality rate, which refers to number of deaths among a total number of cases. Normally, when we do what sort of investigation, outbreak investigation that require these is certain diseases that has serious health impact. For example, leptospirosis, I think. From what we know, like in certain cases, in certain places in Java, in Jogja, Bantul, the case fatality rate for leptospirosis can go up to more than 10%. So that means 10 out of 100 people who were positive leptospirosis were dead. Here is just example of the correlation. I think you can easily see, right? For example, of 1,150 staff and students at the school, 10 develop measles. Then the attack rate is 10 per 1,150, which gives you an attack rate of 0.9%. and so on. Uh, is it just enough? I mean, does it stop there? Once we get the attack rate? No, I think it's not. It should continue to the next step, because we don't just calculate the number of, the magnitude of outbreak in this case. It's not just only about calculating like how many people, what is proportion of people that are actually impacted, but we also wanted to know why do they get infected? Who are those who are more impacted? So therefore, then we can ask this why question, why and how question by developing further hypothesis, and then do some analytical epidemiological analysis. We can see it there, yeah. And how to answer that hypothesis, for example, is by using a quantitative study design. It can be cohort. Cohort study is normally being used in a close population outbreak. Close population outbreak means that we are sure that we can capture all of the population. The easiest example will be a school-based outbreak where we know everyone there. We have the list of the names, so we can investigate all of them. So we can use a cohort in that instance. But if it is happening in community, for example, or in healthcare setting, then I think it's more preferable to use case control, because then what we need is we need to find the cases and then find the suitable control, and then uh, do the investigation and compare the statistic being of what being happening in cases, and then compare it with the statistic of what being happening in control. What I mean is here is that, like, what is the probability of cases, for example, um, eating eating the food that's causing food poisoning outbreaks compared to what the probability of control of eating the same food that are causing the outbreak. I think more examples uh, is coming. We can also do environmental investigation. For examples, we can do food and environmental sampling. Again, easiest example is during MBG food poisoning. Of course, then we need to sample the leftovers food because we wanted to find out what are the agents that contaminated the food. And then we also need to confirm that from human samples. In this case, probably if they are vomiting, so it's going to be those samples. We need to double check whether the whatever pathogens that we found in the food are the same pathogens that we found in the vomit. So therefore, we can then draw a firm conclusion that, oh, okay, this outbreak is caused by a contamination of this agent in this food. You know what I mean? And in terms of environmental investigation, we can also take a samples of, for examples, then we wanted to know how come that food got contaminated by certain uh, pathogen, for example, right? Then we wanted to know whether it is contaminated during the cooking stage or during the packaging stage, and so on and so on. Therefore, then we can do environmental investigation by visiting the SPPG and then see how they handle food, maybe take samples from the water that they use to wash the utensils, the any tools that are associated with food processing and food shipping, and so on and so on. And lastly is, of course, laboratory investigation, which ideally aim to, to confirm whatever agents that are being present in the food or environmental or the human samples. Then we do more calculation. In epidemiology, we like to do calculation. That's why it's boring for some people. I know some of you there maybe feel epidemiology is a boring subject, so that's why you don't take epidemiology major or is it specialization. Then we do calculation that that will inform us what next to do in terms of controlling the outbreak. For example, in here, this is just example. I think same, just like a food poisoning. We do have 21 people eating a buffet-style lunch at the restaurant. Then they reported illness. The onset of their onset of diarrhea and abdominal pain within 6 to 24 hours after they eat the meals. And then based on the food that they are eating, based on the incubation period and clinical symptoms, we suspected them to the pathogen to be Clostridium perfringens, and then we know it is the cause of the poisoning is from the spore. It is spore forming bacterium. It releases toxin and so on and so on. So we learn about the characteristic of the pathogens, and then we do a further investigation. In this case, what we can do is that we calculate the attack rate. For example, there are specific for those who ate certain food or drink certain drink, for example. Let me just go to the next example. Analytical epidemiology. Wait a second. No. Okay. Have the student got previous information on relative risk, Pak Lukman?
Not all student, but majority got this material.
Oh, okay. Okay. So how do I say it? Because I assume you. Okay. So basically, the relative risk is a comparison between the attack rate among people that are exposed to certain risk. Let's say it here, the attack rate among those who ate what we call it, who ate certain food that causing the outbreak compared to the attack rate among those people who did not eat those food. And then based on that, we can actually calculate the what you call it, the probability of people or the risk of people of getting food poisoning outbreaks if they eat certain diseases that are causing the outbreak. I think it's quite hard to digest if we don't have a practical session, I believe. But don't worry about it. I think you can ask Pak Lukman later on because it's quite intensive thing to explain online. And now once what happened next, once we then find out the relative risk, meaning that we then will be able to identify what sort of let's say use food, what sort of food that are causing um, the food poisoning. Then based on that, we can plan and implement control and prevention measure. And again, the epidemiological triad is always a useful framework that we can use to do control and prevention measure. For example, I think I do have the example in a next slide here. For example, if it is a foodborne outbreaks, then example that we may want to do is it can be like first do sanitation, clean up, discard or implicate and other foods. That means that once we find out that certain food is causing the food poisoning, then we get rid of it. Or if we know that the foodborne outbreaks is due to contamination from, let's say, a well, sumur. Maybe what we can do is then do some chlorination, or even just close the sumur, the well, don't use it. Okay, that's one thing to do. If it is caused by, for example, contamination from infected or infectious food handlers, example of it is I remember in 2011, I think, close to New Year's of 2012, I think Pak Lukman and I we we were investigating um, a hepatitis A outbreak in one of the area in Kulon Progo district, and then we were there. We went to the field, um, and one of our findings in the field is that there is a cluster of outbreak of hepatitis A that was caused by eating a food from similar sources. So there was a rapat anak sekolah, and then those kids from certain SMP they got infected. They have clinical symptoms of hepatitis A, and then we were able to investigate and then find out that, oh, okay, they were eating similar food, and then we went to the food vendors who happened to be Warung Padang at the time. And then when we did investigation, when we did interview with the staff, with the food handlers, we found that one of the food handlers was also having a clinical symptoms of hepatitis A, clear symptoms of hepatitis A, because uh, at that time one of the food handlers also had jaundice, kuning in their eyes and in the nails, kukunya. And then from what we found out is that the food handlers didn't have good hygiene practice. Like, hepatitis A is a fecal oral transmission, right? So the virus stays in a fecal, in the feces of infected people, and then it has to go through our oral, through our mouth, and we have to digest the virus. So then we will be able to get infected. So in that case, we found out that the food handlers didn't wash their hand every time they went to they went to do their business in toilets. So after that, they didn't wash their hand properly with soap. Of course, we need soap, so then we will be able to get rid of the virus, right? So then we established that those food handlers were the source of the outbreak. Therefore, we recommended for the food handlers to stay at home, and then for the warung to be closed temporarily. And so many other things that we can do. It can be education about how to properly handle food. It also can be education for the school. I think in context of MBG, it can be education for the kids as well to acknowledge if something goes bad. For example, anak-anak sekarang kan tidak tahu ya, anak-anak kecil, those kids like anak TK or like kelas 1, kelas 2 SD, they don't necessarily know if foods are bad, basi. Mereka nggak tahu kan, kadang-kadang dipikirnya, ayam ini kok lengket, oh ini kecap. Mereka tetap makan. So this also education can also be um, one thing that we can do, educate the kids that, it smells bad, then don't eat it. If it is sticky, lengket, don't eat it, and so on. Premises closer ini yang tadi, when we close the business, we close the food vendors. In this case, probably it's too radical to close SPPG, right? That will be, I think, politically incorrect in this situation. And some other examples from other outbreaks. If it is, transmitted from skin to skin contact, then the measure will be avoid contact. If it is airborne, probably we need to do isolation, wear mask, wear PPE, personal protective equipment for medical care, and so on and so on.
Sorry, Han, I interrupt your talk. There is a
Sure.
question. There is a question from the chat from Saskia Darussalam. I think she is a bachelor degree. How should we redefine what constitutes an outbreak in this era of syndromic and digital surveillance, where early signal often appear before confirmed case?
Yeah, I think that's a good question. Of course, defining outbreak is one thing, but then detecting potential outbreak is also another thing. But what important other than just seeing it, whether it is an outbreak or not? I mean, um, the important thing is that with the technology nowadays, I think we can easily do an alternative. I will say it as an alternative because we don't want to change what's being implemented now. What we can do is that to utilize information. For example, one of my colleagues at Monash, like she did a research where she validated the use of a Google search trend. So what she did is actually she extracted data of Google search, so like how many numbers of Google search over time in 1 year, 2 years, and 3 years, and then she tried to link that. She tried to describe that over time, and then try to link those trend of Google search increase or decrease with the trend of case finding that being reported in our surveillance system. And then what she found is that actually, like just like what the point of the question, actually, like the trend being captured by the Google search, like actually the increase precede the detection in our system. That means that actually using those alternative surveillance might be really useful because that will means that we probably can capture if there is a signal of outbreak, we probably can capture it just based on looking at the Google search trend because people nowadays have access to internet, so and then they can easily buy a paracetamol and so on and so on, and so that's information useful, I think. What I wanted to say in here is I think we should, as academics, as a public health, as a fresh public health graduates, for example, we should um, promote we should promote and what you call it we should promote and keep adding new evidence on how useful this kind of surveillance is in informing or in detecting potential outbreaks in reality, because we know that our surveillance system is bad. I would say it's bad because of many reasons, because of uh, undiagnosed people, because people are not necessarily come to the Puskesmas if they are sick. That means that they are not being captured. The surveillance system, there is a gap from case finding to reporting. At some point, probably in some places, probably cases being happen in last September will be reported in last October, which means that we cannot really rely on the surveillance data to prevent outbreak. So I think it's a good initiative, and I'll encourage young public health professional to keep exploring this kind of alternative surveillance approach. Who knows? Probably in the next, I don't know, 5 years, then we will all be relying on this kind of surveillance. I hope that answered the question.
Okay,
So
thank you.
yeah,
We have one more question before you
yeah,
continue
sure.
the slide.
So
Sis Chantika from Bachelor Degree of International Class. The question is, there are several time comparison, yeah, our or historical data to confirm an outbreak, starting from looking at the case from the previous month, from the previous
mhm.
year, from or looking at the specific period. Then how do we determine an outbreak if there are many time comparison for us to declare an outbreak?
Yeah, good question. First of all, it's not for us to declare an outbreak. Like I said before, it's the call is for the Bupati. It's not for us to declare an outbreak. And second of all, it's really hard when we call something as an outbreak. There is an implication that those sick people, those vulnerable population, will no longer be covered by BPJS, and not every Pemda can cover the cost related to that. And thirdly, I think there is a guideline on how to say certain thing as an outbreak. I forgot the official name, title of the guideline, but I think you can Google it. or maybe Pak Lukman remember it better than me. But I think there is certain criteria that will guide us to call an outbreak. Yeah, you are absolutely correct. It can be comparing what happening this month with what happening similar month in previous year. It can be comparing what happening this month compared to last month. So there's many things, but the key thing, I think, the important thing for us to act as public health professional is that if it is unexpected, meaning it's unexpected from 0 to 1 or from 2 to 4, or we've never seen something like that, then we can consider it as outbreak. But when we consider it as outbreak, it's already too late, right? It's actually already too late. So I would say it doesn't really matter to judge or to say something as an outbreak. But what matter is that we can capture if there is if the trend is showing that there will be likely an outbreak. Because if outbreak is already happening, that means that I think we already too late to act. And all about public health is about prevention, right? Prevention and control. Um, in ideal world, we don't want to do outbreak response. What we want to do is to prevent outbreak, right? But once the outbreak is happening, of course, then we need to do respond as part of our ethical and legal what you call it responsibility. I hope that answer. I cannot answer give you 100% right or wrong answer, but I think the important thing is that the way we think about it is not the defining the outbreak is matter. What's matter is that we can detect the outbreak and then we can act promptly uh, so that the outbreak is not happening.
Yeah.
Okay.
Sometimes the sense as an epidemiologist need
Yeah,
the sense.
exactly. That's true.
Okay.
Yeah.
You can continue
So
your slide.
yeah, I think I just have a couple last slides. Then of course, after we establish the outbreak, confirm the agent, we confirm the mode of transmission. We know how the outbreak, what is the risk factor of outbreaks. Then what we need to do is communicate the findings. It can be, of course, first of all, we need to communicate the findings to public and stakeholders so that the public are aware that certain outbreak risk is associated with certain things, for example, like eating in a specific food vendor, so that they can avoid that, not eating there for a while, and also importantly for stakeholders, then to be able to, act accordingly based on what we found. Um, that leads to the second point, that is findings from outbreak investigation is intended to inform decision about the action to cut the chain of transmission if it is infectious diseases, or to just simply stop the outbreak from happening in the future if it is like acute outbreak like food poisoning and common source outbreak. Um, Lastly, document the investigation. Of course, this is also important. We need to make it written, write the report and findings, publish it, write it down. Maybe if it's not as scientific papers, it can also be like popular article, so that uh, lay person, public, community, and maybe future decision makers can learn from that, so they do not repeat the same things in the future, right? Because if we get something documented, published, then we can then look back at what happening before, and then probably use the previous findings to do some mitigation in the future. uh, I highlighted here, like it's always better to over communicate, even though it comes with some risk, of course, right? If you communicate things about food poisoning outbreaks happening as part of MBG, for example. Of course, it comes with some risk, right? You might get phone, you may get called and saying that, hey, um, keep your mouth shut, and so on and so on. It's the reality. I mean, there is a concern politically because of, this is a new policy, and we need to be careful when we communicating. So I think pick up your battles if you are students. Maybe do communication in terms of scientific form, not necessarily in terms of, not necessarily like writing it down on newspapers or go talk to the news, because what you are communicating can easily be twisted by the news, because what they want is money, attention, not the truth. Sometimes they deliver the truth, of course. The 10th step is I think this is the final step. Then after we do the dissemination, of course, we need to do the follow-up. Follow-up in here can means that we need to make sure that whatever we advise to the stakeholders, to the policymakers, are being implemented. For example, if we advise them to close a certain warung because they cause an outbreak, we need to make sure they do it, right? We need to keep following up the trend, whether the cases really slowing down or already stopped. If not, then probably means that the control measures that we are implementing is not working, which means that we need to think about something else. We also need to ensure that there is no new geographical areas that are being affected, because some outbreaks can easily, transmit cross administrative borders, especially if it is, transmitted via air, airborne, or via skin-to-skin contact, and so on. So it can easily be spreading to new geographical settings, and we wanted to make sure that not happening. One way to do it is to do what we call as cross notification, right? So from one puskesmas to another puskesmas, they need to communicate, they need to check whether in other puskesmas they don't also observe similar patterns, or they don't observe certain increase in numbers of similar cases, and so on, so on. Yeah, we in monitor the situation. Yeah, there's a lot of things you can do to monitor the situation. It can be continuing active surveillance, meaning that you can still go find the case actively, or just stand down and resume passive surveillance. Just wait and see whether we can also whether there are more cases coming to the puskesmas or the hospital, and so on and so on. Okay, I think this is going to be, is it my last slide? Okay, not really. In reality, those 10 steps is not necessarily happening simultaneously. It can be, maybe we will likely miss some step, for example, because of the nature of the outbreak. You know what I mean? Because like racunan makanan, probably we cannot do a proper step by step. It is okay. The important point is that we can then find out the mode of what causing the outbreak. We can then treat the victim of the outbreaks. We can then formulate the control and the prevention for the future, and so on and so on. In reality, yeah, that happened. I mean, the steps not necessarily happen simultaneously, because sometimes we need to act quickly. Sometimes we don't. Let's give another example. During COVID-19, right? During COVID-19, early COVID-19, even though we haven't confirmed, the diagnosis for some people, when we do contact tracing, um, before knowing that they are positive or not, what we do is that we quickly isolate them, right? Quarantine them. Same thing happened when we find some people who have a common cold during the pandemic, who have a fever. What we do is we quickly isolate them, treat them regardless of whether they are actually COVID-19 or just common cold, right? Because the situation at that time is what you call it is it's a crisis, it's critical situation, and what importance and what is public health, what is correct in terms of public health is that we need to save lives. So saving lives in this case is a priority rather than doing PCR, especially if you remember in the early state of pandemic of COVID-19, the diagnostic capacity is really limited, right? So we don't wait to confirm cases, but instead we just act even without confirming the cases. Um, Lastly, communication is key. Uh, yeah, that's true. We need to we need to build a good communication not only within public health professional but also with public, with health cadres, with lay people, with scientists and so on, because often in dealing with outbreaks, we need multidisciplinary effort. So that's why uh, we we cannot working in a you know what you call it in shallow. So we need to connect, communicate to each other. I think COVID-19 taught us a lot about this. Like communication is key. We need to coordinate, between some people need to do risk communication. Some people need to do the contact tracing. In this case, epidemiologists. Some people working in hospital need to make sure that the health supply, like the bed, are sufficient to to treat patient. Some people need to make sure that whatever we need in terms of like the PPE, medicines are there when we need it. So it's a collaborative effort of multi sectors and a multidisciplinary team. Okay, I think this is my last slides, Pak Lukman. I sorry, I think you yeah. Okay. I realized that I think the title on the invitation and also on the poster is about outbreak preparedness and response. But why I talk a lot about outbreak detection, investigation, and also response? Because I think that's crucial, especially for epidemiology students. I think that's crucial. While for preparedness, it's also really important, but it's what do you call it? It involves a really broad scope. So if we talk about outbreak preparedness, it will include many layers. So if we refer ourselves to this WHO health system framework, preparedness will mean that we have to have a preparedness in all of these WHO health system building blocks, which means that we do need to have a leadership. I mean, for example, if outbreaks happening, who's going to lead? During COVID-19, we do have a BNPB. Sorry, not BNPB. We do have a what we call it, COVID-19 task force. We form a new body like KP Japan. That means that in this case, when we talk about preparedness, we should talk about all of this. For example, are we ready in terms of a leadership? Do we have a governance? Who's going to be doing what? Do we have a trained epidemiologist in each puskesmas, for example? If we talk about preparedness, right? Ideally, we do have field epidemiologists in each of puskesmas. Do we have a legal framework? You know, we do have it. Who's going to say it? What about healthcare and financing? Are we ready when outbreaks happen, when we declare outbreak? Are we ready to cover the whatever cost or financial implication that might happen with it? What about health workforce? Not only about epidemiology, not only about epidemiologists, but do we have a proper number of doctors, proper number of nurses to, to respond to certain outbreaks, for example? Do we have a medical products, technology, especially if it is a new emerging diseases? You remember when during COVID-19, we have a very limited diagnostic capacity. We really have a very limited PCR at that time, so therefore we were not ready. What about information system? Are we ready in terms of the information system? We know after COVID-19, then we do have a lot of information system, right? We do have what we call a SMILE. We do have a NAR, National, what we call it, All Record. Now we do have one Satu Sehat and so on. And the lastly is also about service delivery. So it's also about um, the preparedness at, for example, at hospital level, at pharmaceutical level, are we ready to respond for future outbreaks? So that's why I think I put this last. I don't want to take it out from the talk, but I think it's just not enough time to discuss all of it. So that's why then I more focus on outbreak investigation and response. Finally, I think these are just some resources. I think I'll share my slides with you. There is a good resource in here where you can play around with a game, a solve called a CDC Solve the Outbreak game. You can click this, you can open it using your mobile phone or your laptop. Then you can play an outbreak game where you will be given a certain scenario and then how to act and so on. I wish we have time to play together, but I don't think so. Yeah, lastly, I'd just like to acknowledge that the slides that I presented today were prepared by many people. Many people gave inputs on it. And I think, thank you very much. That's it. I also put some data for food poisoning simulation outbreak that you can use later on your time. Thank you very much, Pak Lukman. I think I'll give it back to you and I'm open for question. Thank you.
Okay.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi. Thank you very much, Professor Henry, for the interesting talk. And now continue our question and answer. After Chantika, we have Pak Hanif. Yeah, Pak Hanif is from doctoral degree, Faculty of Medicine. His question is back to the phenomenon of MBK cases. How do you assess the current food surveillance system and outbreak in food poisoning response mechanism in Indonesia? Number one, and number two, in your opinion,
Sorry, Pak Lukman. Can you say it again? Sorry.
Okay. Question number one, how do you assess the current food surveillance system and outbreak response mechanism in Indonesia? From Pak Hanif.
Oh, well, that's hard, Pak. Thank you very much, Pak Hanif. I didn't expect to get a hard, really hard but interesting question. And thank you very much for joining, Pak. I thought all of the participants are undergraduate program students, but luckily we do have some doctoral student as well, which is really great. Yeah, I think for the general surveillance and outbreak investigation for food poisoning, there has been a system and there has been guideline from long time ago. I think Pak Lukman also remember. I think it was written for the outbreak guideline. It was written by Pak Solah Imari, right?
Yeah.
One of staff used to be staff at Ministry of Health. One of field epidemiologists, I think. I think in terms of the step by step of how to investigate and prevent outbreak, the system is there. The generic system is there, but I believe we don't have a specific system. For example, like when we do, let's just bring back the case of MBK. When we do this MBK implementation, of course, then the food poisoning, the surveillance and also the food poisoning investigation will be different when we compare it to, food poisoning surveillance happening in the community, and due to unknown source of food, right? I think, in my opinion, uh, surveillance and outbreak prevention in community is harder compared to uh, preventing, doing surveillance and preventing outbreak in school setting, especially in the context of MBG implementation. Why do I say so? Because we already know who's the food providers, right? So if we find the cases, we know for sure how to find the cause of the food poisoning, and we know how to improve it. We know how to talk to, right? And then in terms of the high risk population, we already know they are the school kids, right? Which also means that we should be able to do active monitoring. Maybe let's call it school-based surveillance, right? Which can involve many parties. Probably in this instance, I'm not sure. Probably the school teacher need to be trained on how to acknowledge if acknowledge like food safety risk, how to handle food properly, because I don't think that the risk of food poisoning is only happening in the SPPG sites, but I believe it's also the food contamination can also happen once the food arrive at the school, right? For example, based on our we did field investigation actually. One of our finding is that in certain school there's also lack of knowledge from the school side, where they, for example, once they receive the food, they just they neglected the food. They put the food just like close to toilet, for example, unhygiene places, that where you know where the contamination, I mean, post food processing contamination might happening, because in many outbreak of food poisoning in community, for example, I'll jump up to community. Sometimes the contamination happen after the cooking process. For example, in kampung-kampung, normally they serve the food in a buffet style, right? And they keep it open. Uh, and then we know that like bacteria like Bacillus aureus can easily contaminate food. They are not, they're not closed with lid, because Bacillus aureus live in dust, right? Di debu-debu di tanah. So once it gets winds, it can contaminate that. So what I'm trying to say is that the generic surveillance is there, but I think in recent implementation of this MBG situation, I really believe that there's need of mitigation plan that involves guru-guru. They need to be trained how to handle food properly, and then I think Puskesmas need to pay attention. Probably do some inspection, if not daily, maybe twice in a week, just to make sure that they keep cleaning things as expected. Because we ask people, we tend to, what you call it, kalau tidak ada yang lihat, we tend to do things and not as it's supposed to be, right? Tidak ada yang lihat nih. Kita kan lihat many videos, right? Like mereka cuma celup-celup, nggak dibersihin dengan benar misalnya tempatnya. Padahal we know quality of our farm aja masih kayak gitu. Sometimes there's coliform contamination in our apa namanya air 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 apa sih, air palm ya. Jadi menurut saya it's a lot of things to do, Pak. I hope that long answer please you, Pak.
Okay, continue with some question from Pak Hanif. He asks about the question like, how about using AI to improve our surveillance system?
Yeah, we do use AI, but not in practice, yeah, I mean, not in public health setting, practice. In research, we do use AI. For example, so I do have a lot of slides actually, but maybe not necessarily in here. What we did at the moment is we try to use AI, for example, for climate sensitive diseases, Pak. Penyakit yang apa sensitif terhadap climate seperti dengue, malaria, and so on. What we do is we use satellite data, data seperti Google Earth gitu. And using satellite data, we can then capture like environmental and climate change. Climate change means like a change in temperature, change in a rainfall, humidity, and so on. And then using those image, we can actually use AI then to help us, like, identify based on certain modeling. Of course, it is advanced. Then we can ask AI to identify, like, which area in this map, for example, they are more likely to have a higher risk of dengue, for example, in certain time, because satellite can capture kalau ada genangan air itu kan di capture ya sama satellite. Genangan air then means that there's a potential vector habitats, and genangan air is associated with rain, ya, seasonality, raining season. Jadi AI can help us to actually identify like which area there is happen to have quite a lot of or consistent genangan air over time, misalnya dalam setahun. So then AI can then quickly calculate that, and then they can tell us, okay, daerah ini dalam setahun ini hampir setiap tahun tuh ada genangan air. Therefore, probably this area need to be targeted for surveillance. Like, surveillance means penangkapan pemantauan jentik, right? We can pantau jentik on probably active case finding for dengue or malaria and other diseases that are transmitted by mosquitoes. That's just one example of it.
Okay. Last two question, Henry, from Pak Didin. I think he's a doctoral degree student too. Several neglected disease outbreaks in ASEAN are still ongoing, especially in Indonesia, such as chikungunya and elephantiasis. And now in Indonesia, I've recently heard rumors of the spread of airborne influenza type A. Have you heard about this rumor in Australia? How does that sound to you after COVID-19?
Okay. Thank you. Thank you very much. 1 second. Yeah, for chikungunya, yes. I think my PhD student and I, we wrote article in the Conversation Indonesia. You can Google it after this. We discussed about chikungunya happening globally and about the rise of cases of chikungunya in Indonesia itself and how we see our current surveillance system, the readiness of our surveillance system. We discussed it there. And the second one was about influenza A, right? To be honest, I'm not really following the trend but I've heard from many of my colleagues colleagues in Jakarta, in other in other ASEAN setting that it is now spreading quite quickly. But probably in a country in a higher income country where they used to have a good coverage of influenza vaccination. We know influenza vaccination is kind of mandatory in many countries, and it's done like annually. They may have a certain level of protection to influenza A as well. This is just my thought, but probably that can explain why the influenza is spreading quicker, like in a country like Indonesia where we don't really have influenza vaccination because we have to pay for it, right? It can cost you as like 400,000, if I'm not mistaken. I just got an influenza shot like last week because it is mandatory by MONES to have it. But we just recently had I can say probably it's an outbreak where we had a gathering of PhD students across MONES campus, so MONES Australia, MONES Malaysia. They visited us in BST, and I found out that a couple of my colleagues got common cold, which I suspect probably is can be influenza A. So yeah, yeah, the human mobility and so on. It's really huge challenge in this instance, but luckily for high income countries where they have a good vaccination coverage for influenza, probably they are less vulnerable than us. But so yeah, keep safe, everyone.
Okay, thank you. Last question from Dina Reza from Bachelor Public Health. Uh, Professor Henry, you mentioned that it is always better to over communicate, yeah.
Ah,
But
I see.
however, in the context of an outbreak situation, how can public health official ensure that frequent communication does not unintentionally contribute to misinformation or public anxiety?
Yeah, I think there is a need of, thank you, that's a good question. There is a need of science of humility. Science of humility. That means that we, even though we are, maybe we are expert, for example, but we need to know what to say, what not to say, of course. And I think a formal channel of communication is needed. When I say over communicate, it doesn't mean that everyone need to say things, right? Those who speak out to public needs to be the one who are really expert in their field. They really know what they are doing. It is best if they are actually someone who have a research on that, have a track record, have a publication history on that. So therefore, we know for sure that I mean they have a public trust and they have a what we call it, credential to say that. So over communication here means not only means that it has to come from expert, but also it has to be delivered to certain group. For example, it is always better to over communicate to policymakers. Do it even daily. Keep reminding them about, oh, come on, this is outbreak, this is serious. You need to do this, you need to do that. That's good. That's good, right? But to public, I think, oh, we need to be, of course, we need to be careful. Well, I think we learn from our very poor COVID-19 communication, risk communication, where our former Minister of Health said that COVID-19 is just like a flu. It will, I mean, it's not a problem, so you don't need to worry about that. That's another downside of poor communication, I think. Um, so yeah, we need to be careful. I agree with you. Do not communicate if you don't know, but do over communicate to correct people. In this case, like to policymakers, to the president, if you have link, of course, um, and so on. Yeah, I hope that give an insight to you. Yeah.
Okay,
Ja,
for
yeah.
example, we as a epidemiologist give like an advocacy to the bupati or mayor wali
Yeah.
kota, and at the end, long story short, she doesn't agree with us about the decision
Yeah.
about the outbreak. It's enough like this, or we can
Yeah.
argue more.
Yeah. Who we are, right? Who we are to argue. I mean, it's like noble person aja. They only can say the message. The messenger can only say the message, right? But they cannot change people's heart. Itu siapa itu ucapan siapa? Jadi ya, sometimes what we can do is just to communicate. But I think sometimes it's not enough to just directly communicate to policymakers. That's why sometimes we need to write something opinion to catch public and policymaker attention. Sometimes we need to write on tempo and so on, because I remember when I wrote the commentary about mitigating risk of vector-borne diseases in IKN. It was published in Nature Communication, but at that time nothing happening. And then Science magazine journalist then interviewed me, and then publish things, nothing happened. Then I wrote the story in the conversation Indonesia with popular article style. Nothing happened. Only until Tempo, then Tempo reproduce it and they tweak my message. They say by saying that opening new land in IKN cause transmission of zoonotic malaria. And then suddenly I got called by the local authority in IKN and so on and so on. So yeah, sometimes the clickbait works, but just make sure it doesn't come from us as a scientist and academics, I guess. That's just example. Thank you.
Okay. I think the time is enough, Professor Henry, for your lecture. But before I close this session, would you please to give us the like a closing statement?
Oh my God. No, I think just thank you very much for having me. My apologies if my slides is too crowded. Because it's normally slides for 3 hours, 3 hours class, and audience like master public health. But in here we do have a under degree. We also have a like a doctoral student. So I hope it's not causing confusion among you. But if you do have a question, please connect. You can connect with me. You can find me on LinkedIn. Just type my name, and then we can have a discussion in other opportunity in other time. I think that's it. Semangat teman-teman, adik-adik yang sekolah ini. Sebagai seorang SKM, pesan saya apa ya? Dream big. Jangan berpikir sempit. Go beyond what you can imagine. Karena public health sekarang kemana-mana gitu. Jadi global health. Go keluar dari Indonesia. Habis lulus dari UNES. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Thank you, Henry, for your interesting talk, speech, and lecture. Thank you very much again. And I will close with the link of certificate and attendance form to all students here, Bapak Ibu S2, S3, and student of S1. You can go to the link and please write your email address correctly, and the certificate will be sent to your email. Make sure that you fill the form before an hour from now. Okay, I will write the link in the chat. Okay, once again, Henry, thank you for your talk. And I will close with Alhamdulillahirabbil alamin and Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih banyak Bapak semuanya.
Thank you very much,
Thank you,
Prof.
Prof. Henry.
Pamit.
Barakallah.
Yeah, thanks, Prof.